WHO has been assessing this outbreak around the clock, and we're deeply concerned both by the alarming levels of spread and severity and by the alarming levels of inaction. We have therefore made the assessment that COVID-19 can be characterized as a pandemic.
The patient is our focus. Our passion for helping others is our drive. Knowledge is our greatest strength. This is the time for pharmacists. Pharmacists around the world are saving billions of lives. Take a picture with the letter P to show that you're on the coronavirus front line.
Good evening, everybody. It's number 40, webinar number 40. Today, I will just introduce our guests in English and in Polish. So we have our friends from Canada, with whom we perform a very nice project about vaccination in pharmacies. So we have Kevin and Alexander. Hello. We also have Eva. She's a pharmacist from Ireland.
Hello.
Hello. How's everybody? We have Bolesław. He's from UK. He's a pharmacist also vaccinating. And we have Marta. We try to rotate, please, Jarek. There's another fifth person. Hello, Marta. And Marta is a pharmacist from Ireland who is also providing vaccines. So now I just talk introduction in Polish because I think it will be very helpful. Dzień dobry Państwu. Witamy Państwa po raz 40. Ten webinar jest wyjątkowy z uwagi na to, że jesteśmy już jednym krokiem tak naprawdę do tego, żeby farmaceuci mogli wykonywać szczepienia. Z tego co widzimy, pierwsze szczepienia, jakie będziemy wykonywali, będzie to COVID-19, więc dzisiaj jak gdyby z uwagi na to, że jeszcze część z Was nie jest może do końca przekonana, my chcemy pokazać, że to jest prosty proces, że można to zrobić i dzisiaj porozmawiamy sobie, będziecie mogli zadawać trudne pytania naszym gościom. Wszyscy szczepią, więc tutaj mówię, tysiące już wykonali, są to farmaceuci. Na razie nikt nie umarł, więc jest dobrze. Moi drodzy, początek oczywiście bardzo, bardzo też ciekawy, wzruszający, to jest nasza kampania Pharmacy Heroes. Ona obiegła 193 kraje świata, w ramach których farmaceuci wysłali kilkadziesiąt tysięcy zdjęć. Jedna z najlepszych kampanii covidowych promujących zawód farmaceuty w 2020 roku pod patronatem Federacji Farmaceutycznej, kilku uczelni oraz Europejskiego Stowarzyszenia Związków Zawodowych Pracowników Farmacji oraz Polskiego Związku Zawodowego Pracowników Farmacji, który też znacie. Moi drodzy, więc przechodzimy, dzisiaj będzie po angielsku, oczywiście też można będzie zadawać pytania po polsku w trakcie do naszych polskich farmaceutów. Dzisiaj opowiemy sobie o tym, jak robić szczepienia, jak przygotować aptekę do szczepień, o tym powiedzą nasi goście z Kanady, więc już zamieniajcie się w słuch. Ja oczywiście serdecznie Was witam na 3 kanałach, Facebook, YouTube oraz Pharmacy College, czyli nasza generalnie strona edukacyjna. Więc moi drodzy, oczywiście podziękowania dla Federacji Farmaceutycznej, OPZG, Ogólnopolski Program Zwalczania Grypy, za możliwość przygotowania tego spotkania dzisiaj z farmaceutami oraz Polska Grupa Farmaceutyczna, bez której zarówno ta fantastyczna kampania, jak i dzisiejsze spotkanie nie mogłoby się odbyć. Więc serdecznie Was zapraszam i generalnie przechodzimy już do naszego pierwszych gości. Więc Alexander and Kevin, please, you can just prepare your presentation. I think it will be very cool, and we also, I will just make some breaks and we'll just ask questions to our guests.
Can you see my slides?
Yes, but maybe, let's do it this way. Let's talk about vaccines first. So what was your first impression about doing vaccines? I know from Regis, our boss, basically, that you started a long time ago and you have lots of experience in providing it. So please tell us about it. Were you scared or anybody died?
We were talking earlier, and as we said, like everyone remembers their first vaccination. It's a pretty daunting thing to poke someone in the arm with a needle. However, after you do it, a couple of hundred times, you kind of get used to the whole situation, and it gets much easier after that. So today, I've been doing flu vaccines for the past couple of months, and so is Alex here. And it's pretty routine at this point, honestly.
Okay, and were you afraid during doing it, or what was the most difficult for you?
The first time was obviously scary. I don't know about Alex, but after you do it a couple of times, as I said, it becomes a lot easier, a lot more routine, and it's today it's just another part of the job, right?
Yeah, it's part of the practice. So we just now ask Marta, how was your experience? Because you're a Polish-trained pharmacist, we don't have vaccinations at the university.
Yeah. Oh, that was great, because my first patient was my boss, so I got all my emotions and that job, and that was great.
So everybody leaves, nobody dies, and now it's fine.
No. And what's interesting, I was trained online, so I had all the training, including the practical training run online, because that was during the pandemic, so it's quite funny.
Excellent. Eva?
Yes, I do remember sticking my first needle in, and I was absolutely petrified. But I'd say, it's just like riding a bike. Once you start doing it, you just get on with it. And I think the most amazing thing of the service is people are coming back year in, year out, and you've got same people coming in saying thank you. So that is the best reward.
Excellent. And Bolesław?
Yeah, definitely the first time it was quite scary, and I need to say, from my experience, I don't like needles, and I needed to overcome this problem. And I had a practical training for it, and I remember on the practical training, I was in the pair with another person, and when they put me with this another person, this person didn't want to go for a training with me, because at the beginning of the training, I said I don't like needles. But yeah, at the beginning, doing the first patient, it was all right. And the next day, actually, this patient came back to the pharmacy for something else, and he was still alive, and I was quite happy as well.
For me, I was the lucky one, because I started my first training was, I think, 2007. And then basically I was living in Cambridge. So, all the young students, I was still single. So it was actually very exciting for me. So thank you, guys. And we just come back to you during the presentation. So I would like to just have our guest from Canada to tell us more about vaccines, about process, about education, etc.
Perfect. Okay. Let me just open up my slides here.
Sure.
Can you see our slides perfectly?
Not yet. We can always ask our IT service to help us, please.
I think there's a way to share my screen, right?
Yeah, I think it's in the left corner.
Oh, yeah, there it is. There we go. Can you see it now?
Not yet.
Perfect.
Now it is. Jarek is saying, yeah, Jarek, I cannot. Okay, I think something's happening. That's good.
That's good?
Perfect.
Awesome. Okay. All right, so let's get started. Hope you guys are all doing well. Some of you might remember me from the last presentation I did on pharmacogenomics a couple of months ago. Today we'll be talking about something a little different, immunizations in the pharmacy, or basically pharmacist-administered vaccines. This might seem a little daunting to you all, because I understand that this is quickly approaching for Polish pharmacists. However, hopefully after this presentation, you'll be able to be a little bit more comfortable with administering vaccines. Just a little bit about myself. Again, my name is Kevin Chung. I am a pharmacist at the Children's Hospital of Eastern Ontario, as well as working with the Canadian Pharmacogenomics Network for Drug Safety. And today we have Dr. Alex Wong with me as well. Hello. He will be going over some things as well. We'll go over our learning objectives first. So the first thing I'll do is I'm going to review something about the economic impacts of pharmacist-administered influenza vaccine in Ontario. We're going to review the immune system as well as the role of vaccines. We will be discussing these new mRNA COVID-19 vaccines, as well as comparing the differences between the two. I'll also be reviewing influenza and the seasonal influenza vaccine. And then Alex will be going over a lot of technical things such as vaccine storage, handling, and disposal, proper injection technique, describing how to select your needle, as well as describing how to assess patient eligibility. We'll also be discussing monitoring and adverse effect management at the end, and also going over these patient surveys that have been completed. So, as I said, first thing I'll go over is the economic analysis of pharmacist-administered influenza vaccinations in Ontario, Canada. So there were two data sets compared from 2011, 2012, and 2013, 2014 influenza seasons, basically evaluating the impact of pharmacist-administered influenza vaccines in Ontario, Canada, pertaining to vaccination costs related to the number of people vaccinated, annual influenza-related costs, such as emergency visits, hospitalizations, and office visits, and then the change in productivity costs as well. So what they had as results were there was a net difference of 450,000 vaccinations between 2 years. So in 2011 and 2012, there were no pharmacist-administered vaccinations, and there were 2.62 million vaccinations during that season. In the 2013-2014 season, there were 3.07 million vaccinations, up to a 3% increase in that case, and 765,000 vaccinations were administered by pharmacists. So as you can see here, the pharmacists actually took away a lot of the vaccinations from physicians and other public health care professionals as well. In terms of money, the increase in immunizations was associated with a $6.3 million increase in expenditure to pay for these vaccines and their administration. However, that being said, the increase in vaccinations potentially saved $700,000 in direct healthcare costs and $7.9 million in productivity costs as well, with an overall savings of $2.3 million. That being said, that's great for the economy, but what about for your pharmacy? Well, it's very easy for a patient to get to the pharmacy rather than going to their doctors. Typically you don't have to book an appointment and they can go after work rather than during work. In Ontario, Canada, our pharmacies are reimbursed $7.50 for each influenza immunization given. However, this is not where the bulk of the money comes in. So if you think about it this way, these patients who are immunized have to remain in the pharmacy for 15 minutes to monitor for any adverse events. So that may entice these customers to buy other items, therefore increasing pharmacy profits. Other intangibles include, just being able to build a relationship with their patients, basically building a level of trust so that your patients are coming back to your pharmacy as well. So the next thing we'll do is we'll go over the immune system. Immunity is essentially the ability of the human body to tolerate the presence of materials indigenous to the body, known as self, or recognize and eliminate any foreign or non-self material. There are two basic mechanisms for acquiring immunity, and those are active and passive. Active immunity being protection that is produced by the person's own immune system, and then passive immunity being protection by antibody-containing products produced by an animal or a human and transferred to a human. So for example, breast milk. And then this picture kind of just illustrates what I just spoke about. So you can either get active immunity through actually catching that pathogen and then getting immunity through that, or through vaccination. Or you can get passive immunity, such as maternal immunity passed through the breast milk or through injection as well. So how do vaccines work? Vaccines contain an antigen that is designed to stimulate our immune system. And this is basically about creating immunological memory. By creating this immune memory, in the case of a subsequent contact with the antigen, the secondary immune response eliminates the pathogen much faster and much more effectively. So we have three vaccines on the market, or three types of vaccines on the market today. We have our inactivated vaccines, such as the influenza vaccine. We have live attenuated vaccines, such as the MMR vaccine, and then we have these new mRNA vaccines, or the COVID-19 vaccine. So just to be topical, I'm going to go over these COVID-19 vaccines quickly. There are two vaccines that have currently been approved by Health Canada. You have the BNT162b2 mRNA COVID vaccine produced by Pfizer and BioNTech. And then you have the mRNA 1273 SARS-CoV-2 vaccine produced by Moderna. Now, these vaccines are very similar in nature. They are lipid nanoparticle encapsulated mRNA-based vaccines that encode for the SARS-CoV-2 full-length spike protein, as shown here. And basically, these mRNA vaccines teach our cells how to make a protein that will trigger an immune response without actually using the virus that causes COVID-19. So these mRNA vaccines basically contain the genetic instructions for making the SARS-CoV-2 spike protein. The lipid nanoparticle contains mRNA inside of it, this nucleoside modified messenger RNA. And this lipid nanoparticle enables the delivery into host cells, allowing the expression of the SARS-CoV-2 antigen. And then that antigen will then elicit an immune response, allowing our body to develop an immunity to it. So these are basically the two vaccines here in the charts. We're looking at the differences between the two. So they're both mRNA vaccines, however, they're authorized for different ages of use. The Pfizer vaccine is available for patients 16 years and older, whereas the Moderna vaccine is only approved for patients 18 years and older. The dose is slightly different as well. The Pfizer vaccine is 0.3 mLs containing 30 micrograms of the mRNA, whereas the Moderna vaccine is 0.5 mLs containing 100 micrograms of the mRNA. Scheduling is slightly different as well. The Pfizer vaccine is 2 doses given 21 days apart, whereas the Moderna vaccine is 2 doses given 28 days apart. They are both intramuscular injections, and they both produce the perfusion spike protein. The primary storage requirements are slightly different. The Pfizer vaccine requires -80 degrees to -60 degrees Celsius, whereas the Moderna vaccine only requires -25 to -15 degrees Celsius. So the freezers that you would use to store either vaccine will be slightly different as well. For storage requirements pre-puncture, the Pfizer vaccine is good up to 120 hours or 5 days at refrigerated temperatures and up to 2 hours at 25 degrees Celsius, whereas the Moderna vaccine is good up to 30 days at refrigerated temperatures and 12 hours at 8 to 25 degrees Celsius. The Pfizer vaccine does require a diluent. It's normal saline, it's 1.8 milliliters, whereas the Moderna vaccine does not require any diluent at all. Post-puncture, they're both good for 6 hours for 2 to 25 degrees Celsius, and they're both available in multi-dose vials. The Pfizer BioNTech vaccine is available in 5 doses, whereas the Moderna vaccine is available in a 10-dose vial. I have here listed the side effects of the COVID-19 vaccine. So the Pfizer and the Moderna vaccines are pretty similar in what they cause for side effects. Both cause injection site pain, fatigue, headaches, as well as myalgias and chills. The Pfizer vaccine also causes a fever. Just a little anecdote of my own, I did receive the vaccine a couple of weeks ago, and I basically experienced all of these side effects for about 24 hours myself. I've also listed the placebo groups for each vaccine trial here, so you can compare the two as well. In terms of contraindications to the COVID-19 vaccines, both these vaccines are contraindicated in any individuals who are hypersensitive to the active substance or any ingredients in the formulations. So I have a couple here that are highlighted, one being polyethylene glycol. So if a patient has a polyethylene glycol hypersensitivity, then they cannot receive the Moderna or Pfizer BioNTech vaccine. I also have tromethamine here. And this one's a little important because you can see here I have ketorolac mentioned here. So ketorolac is formulated with the tromethamine salt, and therefore a patient might actually be allergic to that salt. So if a patient comes in and is allergic to ketorolac, they are not eligible for the COVID-19 vaccine as well. Next thing we'll go over is a bit about infection control. So we're in a bit of a pandemic at the moment. So we want to make sure that we're wearing proper PPE. We're making sure that we're washing our hands before each patient, wearing gloves, wiping each vial with alcohol as well as the injection sites and allowing those to dry, using proper technique in reconstitution and withdrawal to prevent any contamination, and then always using a separate sterile needle and syringe for each injection and disposing your syringe in a special container designed for SARS. So we can see our friend here is decked out in full PPE. He has his face shield on and or goggles. He has a face mask, a pair of clean, non-sterile gloves, as well as an isolation gown. The transportation of the COVID-19s is a little bit tricky. So Pfizer recommends that their vaccine be shipped in a frozen state as per the product monograph. However, sometimes this may not be feasible in the context of, let's say, a public health emergency, which we're in right now. So therefore, we would have to ship the vaccine out to clinics or long-term care homes in order to vaccinate patients there. So that being said, the vaccine may be transported beyond the initial point of delivery. It is recommended that the vaccine is packaged for delivery in a frozen state to be transported to the clinic or facility location using an insulated cooler that has been preconditioned to a refrigerated temperature of 2 to 8 degrees Celsius. In this state, the vaccine should not be in transport for more than 8 hours, and open or reconstituted vials should not be transported, and products should be sent just in time as a part of a planned vaccination clinic. So these next couple of slides I basically adapted straight from the Pfizer-BioNTech COVID-19 vaccine monograph as well as the Moderna one, so you can find them there. However, this is just to go over the preparation of these vaccines. So for the Pfizer vaccine, you'll want to remove a thawed vial of the Pfizer-BioNTech vaccine from the refrigerator, allowing it to come to room temperature. It takes around 2 to 3 hours for a vial to thaw in the fridge. If the vial is frozen, you should allow it to thaw for 30 minutes at room temperature, and making sure that these vials at room temperature must be diluted within 2 hours. Before dilution, you'll want to gently invert the vial 10 times, making sure not to shake it. You don't want to agitate these vaccines because they are very delicate, and any harsh movement can definitely make the vaccine innate. So the next thing you'll do is you want to prepare your diluents. So you'll obtain 1.8 milliliters of the 0.9% sodium chloride for injection. You'll cleanse the vial stopper with a single-use antiseptic swab, and you'll add your 1.8 milliliters of your sodium chloride injection into the Pfizer-BioNTech COVID-19 vial, vaccine vial, using a needle that is 21 gauge or narrower. When we're doing this, we typically hold it over at an angle and dribble it in over the wall rather than going directly into the vaccine, again, just to avoid any sort of harsh agitation. You'll then want to make sure you'll equalize vial pressure before removing the needle by withdrawing 1.8 mils of air into the empty diluent syringe as shown here. You'll then gently invert the vial 10 times to mix again and record the time and date of dilution on the vial label. And you can then store the vaccine between 2 and 25 degrees Celsius, discarding any unused vaccine 6 hours after dilution. In terms of actually preparing the Pfizer-BioNTech vaccine into your syringes, you'll use aseptic technique, cleansing the vial stopper again with a single-use antiseptic swab, and then withdrawing 0.3 mLs of the Pfizer-BioNTech vaccine, and making sure to administering this no later than 6 hours after dilution. In terms of the Moderna COVID-19 vaccine, it's a little bit simpler because there's no diluent involved. So you'll want to thaw the vaccine in refrigerated conditions for 2 hours and 30 minutes, letting each vial stand at room temperature for 15 minutes before administering. Alternatively, the vaccine can be thawed at room temperature between 15 to 25 degrees Celsius for 1 hour. You want to make sure that you never refreeze the vials after thawing them. And again, as I mentioned before, no reconstitution or dilution is required. You'll then swirl the vial gently after thawing, and then between each withdrawal, making sure not to shake the vaccine again. And using the aseptic technique, you can cleanse the vial stopper with a single-use antiseptic swab and withdraw 0.5 mLs of the vaccine using a new sterile needle and syringe for each injection, making sure that you use the dose in the syringe promptly. Next thing we'll go over is the seasonal influenza vaccine. I'm sure most of you have had influenza before. However, the seasonal influenza is an acute respiratory illness caused by influenza A or B viruses. It spreads quickly from person to person through contaminated droplets such as coughing or sneezing or contact with contaminated surfaces. Certain symptoms include sudden onset of high fever, a dry hacking cough, muscle aches and pains, headache, fatigue, congestion, and a sore throat. So here I just have listed some of the influenza vaccines that we have on market. So we have our trivalent and our quadrivalent influenza vaccines, which are inactivated. We also have a high-dose quadrivalent vaccine, which is approved for patients aged over 65 years. And this basically contains 4 times the standard antigen dose, just to increase antibody production. We also have a live attenuated influenza vaccine called the Flumis quadrivalent. And this is given as an intranasal spray, 0.2 mLs divided in 2 doses between the 2 nostrils. So these are your patients who are at risk of influenza-related complications. So all pregnant patients, adults and children with chronic health conditions such as cardiac pulmonary disorders, diabetes, cancer, renal disease, neurologic or neurodevelopmental conditions, or morbid obesity, as well as residents of nursing homes and other chronic care facilities, and individuals over the age of 65 years of age. So for contraindications to the influenza vaccine, it's basically contraindicated in any patients who have a history of anaphylaxis to their previous dose of their vaccine, or anaphylactic hypersensitivity to any of the vaccine components, with the exception of eggs. And then patients under the age of 6 months as well. In terms of precautions, if a patient comes in with an acute febrile illness, such as a high fever, you'll want to delay the vaccine until the patient is healthy. However, if it's a mild, non-serious febrile illness, then they may be given the influenza vaccine. However, in today's world with COVID floating around, I would typically not want a patient with a mild, high, non-serious febrile illness with a respiratory tract infection coming into my pharmacy anyways. I did mention egg allergic individuals as well. So the National Advisory Committee on Immunization has concluded that egg allergic individuals may be vaccinated against influenza using the trivalent or quadrivalent influenza vaccine without prior influenza vaccine tests and with the full dose regardless of a past severe reaction to eggs and without any extraordinary precautions. And then I'm going to pass this over to Alex now. He's going to speak to you about the cold chain.
So first, starting with the cold chain. So the cold chain refers to the process used to maintain optimal conditions during all stages of handling the vaccine. And failures of the cold chain are called breaches. And so they can occur at any stage in the process. So the cold chain refers to, on the right here, from vaccine manufacturing all the way into the actual administration. The cold chain should be maintained throughout the whole process to ensure that the vaccine is still effective and it's still safe for the patient when it gets to their arm. So moving on to the vaccination workshop. I just want to mention that this is not an accredited course. I'm just going over some basics on how to do vaccinations, selection of needles, things like that. So this is not an accredited course. This does not give you the permission to inject. This is just for your information. So other things that I will not be discussing. So we're pharmacists practicing in Canada, so the legal requirements between Canada and Poland may be different, so I will not be going over those. I will not be discussing informed consent, but I won't be going into detail, but basically you want to be discussing the risks and benefit with the patient. You can't coerce your patient into consenting for the vaccine, and they have to be deciding on their own. I won't be discussing CPR or first aid requirements. In Ontario, we as pharmacists need to renew our CPR every 2 to 3 years to be able to vaccinate. I won't be discussing which course you actually need to take to give injections, and I won't be discussing the age of injection. So I can tell you that in Canada, pharmacists can vaccinate children aged 2 and above, but this may vary in different jurisdictions. And there's also mandatory reporting to public health. I believe Polish pharmacists as well as Canadian pharmacists have a mandatory duty to report any side effects or adverse reactions to public health for further monitoring. So moving on to patient preparation. When booking your appointments, you need to remind patients to wear clothes that will facilitate access to their arms. So something like a t-shirt or a sweater that can come off easily. The key here is you want to be able to access the injection site easily. So if they have a long sleeve, but they can roll it up, that could work. Or if their collar is a little bit looser, you can also pull that down the shoulder. But you definitely want to prep them and tell them to wear clothing that can access the injection site easily. So in this case, it's the upper arm. You also want to ensure before starting that the patient has enough time to be monitored after the vaccine. So typically 15 minutes, it can be up to 30, and I'll go over that in a few slides. Make sure you introduce yourself as the pharmacist, and if possible, prepare the vaccine and give the injection out of sight of the patient. And so you can prepare the vaccine out of sight and instruct the patient to look the other way when you're giving the injection. And so I also encourage you to use distraction techniques for both adults and children. In terms of adults, we can just make small talk, ask them how their day is going, things like that, just to get them talking, to help minimize nerves. For children, there's different options. You can offer them a reward after, like candy or a sticker. You can put on a video on YouTube that the kid enjoys. So these are all possible distraction techniques that we can use. Another thing too is that you can explain as you're preparing the vaccine. There's a lot of people who are very curious when I'm preparing the vaccine, and so you can see them. They're looking over. They're trying to see what you're doing, and so in these patients, I tend to explain step by step what I'm doing, so it helps to minimize anxiety and also teaches them a thing or two. But just be careful, because if the patient is very scared, this will probably work to your disadvantage and make them more nervous. So moving along to patient assessment, prevention of anaphylaxis is a critical component of this. So pre-vaccination screening includes screening for history of anaphylaxis and identification of potential risk factors. So we want to be looking at, of course, we're going to collect demographics. We want to be going over the medical history, as well as if they've had a history of neurological problems. And so this is not so much a concern if it's the influenza vaccine, but for example, the Tdap vaccine may be contraindicated in these people. So I do want to say here that the influenza vaccine can rarely cause GBS. I'll be going over that in a few slides, but this is a very rare side effect, and unless they've had the vaccine and GBS within 6 weeks of each other, it's probably not related. But in either case, you would probably want to do this in a physician's office or in a place where you're well equipped to deal with these types of adverse reactions. You also want to be seeing how they're doing today in terms of, do they have a fever? How are they feeling overall? Are they feeling lethargic? Things like that. So I'll be going over what to do if the patient presents with a high fever in a couple slides. And you also want to be looking at if they've had any previous reaction to any vaccine, and that would prompt you to look further. And also allergies, so medications, foods, and components of specifics to the vaccine. And there's some foods that have cross-reactivity with things you might see in during a vaccination. So it's very important to collect all of this information. And finally, for the flu vaccine, it's okay, but if they are receiving a live vaccine, typically the recommendation is to wait at least 4 weeks or 28 days between both doses. But like I said, not a concern for inactivated vaccines, such as the flu vaccine. So I'm going to go over the form that we use in our pharmacy. This is the first part of the form where we are describing, so you have the patient fill this out, just their basic demographics, emergency contact if anything happens. Moving on, this is the screening. So I've already talked about some of these. So we talked about we'll talk about fever in a little bit. If they've had difficulty breathing, wheezing, or chest tightness within the 24 hours of getting the flu vaccine, that might require administration in a doctor's office or in a place where you can deal with allergic reactions like this. Of course, if they have an allergy to any part of the influenza vaccine, if they've had a severe life-threatening allergic reactions, you should investigate on what kind of allergy it was. You have to make sure it's not a side effect and make sure it's a true allergy. And again, if it is a severe life-threatening reaction, again, you would want to be in an area where you can treat this patient at a moment's notice. We've gone over allergens, and I will go over them separately on the next slide. GBS we've talked about. If the patient has bleeding problems or blood thinners, generally okay to proceed. You just have to monitor a little bit more and just be aware that there may be a little bit more blood that comes out, if any at all. Are you pregnant nursing, or do you intend to become pregnant? This is not a concern with the influenza vaccine. This is more so a concern with live vaccines. Just know that for the flu vaccine, there's very few contraindications. And Kevin has gone over that previously. And in this bottom section here, this is for the live intranasal vaccine. So again, you would want to screen for things like this to make sure that you're safe to proceed. So if the patient ends up checking yes to any of the questions. So for example, if they've had a live vaccine in the past 28 days, or they have a fever above 38.5, then you may want to consider rescheduling the immunization in a few days or a few weeks, depending on when they're due. So for example, you should wait at least 28 days, and you should wait probably until the fever subsides to a mild fever or no fever. If the patient ticks that they have an egg allergy, you can vaccinate patients with egg allergies because, as Kevin has mentioned, there's actually been at least in Canada, we are allowed to vaccinate with the flu vaccine in people with egg allergies, despite regardless of the previous reaction to egg or any sensitization to the vaccine. And you can also vaccinate pregnant patients, again, as long as the vaccine is not live. And so in the case of the influenza vaccine, it's not a live vaccine, so you're safe to proceed. And now in cases where you would not want to vaccinate in the pharmacy, so for example, if they've had any reaction, including anaphylaxis to a vaccine component, or they have unstable or new neurological disorder, you might want to refer them to a physician's office. This is the form that is completed by the pharmacist after the injection. So I've completed the form here, so as I would complete it normally. So we have single-use syringes that they're pre-filled. So I've ticked this flu zone, which is the name of the vaccine. And then you date, you time, you put the lot and expiry, and you put your license number and your signature and stuff like that. Immediately after the injection, you should tick if they've had the left or right arm injected, or intranasal, if this is the case. And you can also tick yes or no if you've contacted the primary physician. And in most cases, we do not end up giving an emergency treatment. So if you do end up giving an emergency treatment, this is the back of our immunization form. We have a section that you can fill out with the information. And so you would fill this out if you're administering epinephrine or adrenaline. So what to do if the patient presents with a fever of above 38.5 degrees Celsius? It's generally better to delay the vaccine if the patient has a fever above this. And why is that? Because studies have suggested that the effectiveness of a vaccine in stimulating an appropriate immune response may be negatively affected by the presence of a fever at the time of vaccination. And also having a fever at the time of vaccination also increases the risk of post-injection fever-like symptoms and muscle aches, for example, because they already have symptoms at baseline usually. And so if you're adding on side effects, then the perception is that they're having more side effects from the vaccine. So if the patient has a temperature above 38.5, you should inform them that a delay until the fever subsides is recommended to ensure the full effectiveness of the vaccine. Now, there may be situations where you can't tell them to come back because, for example, they may be leaving the country and they won't have an opportunity to get vaccinated in that country that they're traveling. And so you have to use your clinical judgment. You should also consider that vaccinating someone with a fever is probably better than not vaccinating someone at all. And so it might be more beneficial to vaccinate that person on that day rather than to not vaccinate. So moving on to allergies, there's a few allergens to monitor for. So the allergens of interest are egg, neomycin, and I'll go over latex on the next slide. But like I've mentioned before, egg allergies are they're common in children, but in most cases, we are safe to proceed with vaccination in people who have egg allergies. Neomycin is a topical antibiotic. This is also, you may also see polymyxin as well. So this is not a concern for the influenza vaccine, but it is present in the MMR vaccine and potentially to your situation. So of course, if they've had a previous anaphylactic reaction to neomycin or any vaccine containing neomycin, you should not give the vaccine. Make sure you refer these cases to the general practitioner or the physician's office or a public health office. Lastly, latex allergies. So these can range from mild to anaphylactic, typically found in gloves or the rubber stoppers of the injection vials. And so typically we'll recommend using nitrile gloves to reduce the risk of allergy in all patients. And sometimes the product monograph will tell you if there's any latex in there in the vials, so you can make a more informed decision. There's also a lot of cross-reactivity with food allergens. So for example, avocado, apple, potatoes, tomatoes are all foods with potential cross-reactivity to latex, and so it's important to also ask about food allergies when you're doing your assessment. And before continuing, make sure you have the right drug, make sure you have the right vaccine, and that the expiry date is has not passed, and that the appearance is as expected. Make sure you have the right dose. In most cases, there's no issue because they're single-use files, and so very hard to mess this up. But also, you want to make sure that you're giving the right dose. Make sure you have the right patient in front of you. You can address them by their first name, and of course, if you have the wrong patient, they will tell you right away. But you should be checking if it's the right patient multiple times. Make sure it's the right route. So in this case, it's going up in the deltoid, the arm. But in the case where it'd be in the thigh or at the back of the arm, you want to make sure that it's the right route, the right area on the body. Number 5, make sure it's the right reason. Make sure they're getting vaccinated for the right reason. If they are going, if they're going traveling, make sure they're getting a hepatitis A vaccine, for example, and make sure they're not getting another vaccine for a disease that's not very prevalent in that area. Make sure it's the right time with regards to dosing schedule. So Kevin went over the vaccine schedule for the COVID vaccines, and so it's very important to give that dose around the 3-week mark for the Pfizer or 4-week mark for Moderna. But you want to make sure that if it's a multi-dose vaccine, you want to be giving the second or third or whatever subsequent doses at the right time. And finally, make sure you have the right documentation. You should be documenting everything that's going on. So as I mentioned earlier, like which arm, like right arm, left arm, is it intranasal? Of course, if it's in the leg, you should mention it's in the leg. And now we are ready to inject. So this is assuming that the patient has been assessed and everything is good to go. Let's proceed. I want to briefly go over the anatomy of the needle and syringe. And so the syringe here refers to the needle and the syringe, but basically you have the plunger here, which you can pull and push to withdraw and inject the vaccine. The barrel is the part that contains the vaccine. The hub and the needle, let's go over to the right side here. The hub is the little plastic part which connects the needle to the barrel. The shaft is the long needle, essentially, that will deliver the vaccine where it needs to go. The bevel is the angled cut on the tip of the syringe, which will help penetrate the skin. And the lumen is just the hole where the vaccine can travel. This is how I set up my vaccine station. Typically, you'll need 2 needles, one to withdraw the vaccine and one to inject. You want a syringe that's large enough for the volume. So typically, you want at least 0.5 cc's, but typically the 1 or the 3 cc syringe is more better at your. It's easier to hold because the 0.5 syringe is quite tiny. You want 2 alcohol swabs, one to swab the patient's arm or the injection site, and the other one to swab the vial if you need to. You want some cotton ball and a gauze and a bandage for the arm. Not pictured here. Obviously, I don't have the vaccine. Gloves are considered optional. This is up to you. Although if you're probably doing a COVID vaccination, you might want to wear gloves. For the influenza shot, not completely necessary. You also want to have a sharps container nearby. You want to have an anaphylaxis kit in case this person develops a reaction. Make sure to wash your hands and sanitize your hands before you continue. So it's important to get an appropriate size needle to ensure that the vaccine is injected deep into the muscle. Vaccines injected into subcutaneous tissue are more likely to cause side effects. And so basically you want to pick a large enough needle so that it can penetrate through the dermis and the hypodermis into the muscle. So there's two principles to know about selecting the needle. So first is gauge, the second is needle, the second is length. So the gauge refers to the diameter of the shaft. So a higher gauge refers to a thinner needle. So you can see here on the bottom right, A 25 gauge needle is thinner than a 10 gauge needle. And so typically you'll be using 23 or 24 or 25 gauge needles for most vaccines. The length of the needle is also important so this refers to the distance between the needle hub and the tip of the bevel. So in this case, it's basically the length of the shaft here. In patients under 60 kilograms, so typically children or small adults, including adolescents as well, you would want to use a 16 millimeter needle, which is 5/8 of an inch. In patients who are 60 kilograms or above, you would want to use a 25 millimeter needle, which is 1 inch. And in patients who are obese, you may want to consider using a 38 millimeter needle or a 1.5 inch needle. Now, I can tell you that I don't use the 1.5 inch or the 38 millimeter needle that often, but you should know in which cases to use it. So withdrawing the vaccine. So if the vaccine is pre-filled, all you need to do is attach the needle and you're ready to go. In the case where your vaccine comes in a vial like this, so this is the case for the COVID vaccine, if you have to withdraw the vaccine from the vial, wipe the top with alcohol and let it dry. And remember that it's the drying of the alcohol that disinfects the surface and kills organisms. If the volume to be withdrawn is 0.5 milliliters or 0.5 cc, you should withdraw 0.5 cc of air into your syringe and inject that air into the vial, which will create a positive pressure, and that will help you to withdraw the vaccine more easily. And once you're done, you withdraw the vaccine into the syringe, and you will double check your volume. Just a reminder here that we want to be checking on this line and not the tip of the barrel. And you'll be withdrawing the vaccine upside down like this to minimize any air bubbles. So just tips to eliminate air bubbles. So if you have a vaccine that looks like this on the bottom right, you need to get rid of that air bubble before you inject anything. And so you can try injecting it back into the vial and trying again. You can try pulling the plunger back quickly when you're withdrawing, which will sort of create a vortex inside the barrel. And that can sort of loosen up stuck bubbles. So these are just other ways to get rid of the air bubbles. As a general rule, you want to have you don't want bubbles to be larger than champagne bubbles. So if you see little champagne bubbles, like very tiny bubbles, that's okay. But a bubble like this in the bottom right picture, you definitely want to get rid of. Now going over to, I just want to briefly go over SIRVA, or shoulder injury related to vaccine administration. This is caused by incorrect techniques or landmarking for intramuscular deltoid injection, where the injection is administered into the shoulder joint, causing inflammation, which can cause damage to the bursae, tendons, and ligaments. The key here to identifying identifying SIRVA is that symptoms typically begin within 48 hours of vaccine administration, and they don't typically improve with over-the-counter pain medication or over-the-counter analgesics. Symptoms can begin within hours, and it can take a few days for it to kick in. And without treatment, symptoms can last for months and may never even resolve. So it's very important that you do correct landmarking, and I'll go over that in a couple of slides. Here, so when you're positioning your patient, you want to make sure they're seated. Ideally, you don't want them standing because there's some patients who are prone to fainting, and so especially if they see needles or blood, that can cause people to faint. So you want to have people sitting down when you're giving the vaccine, just in case. Instruct them to sit upright, arms relaxed. You don't want the arm to be flexed. You don't want the muscle to be firm, otherwise it can cause a little bit more pain, and it's just there's a little bit more resistance when you're injecting. You should position yourself on the side that you're injecting. You should not be reaching across the patient. So basically, position the patient so that their arm, the injection site, is facing you. So to landmark the deltoid, you want to feel for the bony, and you can do this along with me. You can feel for the bony process on your shoulder called the acromion process. And you want to be putting down 2 or 3 finger widths below the acromion process. And the end of that is where your zone of injection begins. So you can see the triangle here. Typically, the zone that you're injecting is about the size of a triangle, is in the shape of a triangle. And the target area here, I've put a little picture here for my Polish viewers. Just it's basically the size of a 2 zloty coin. That's the sort of area that we're trying to aim the vaccine into. And the lower limit is typically the axilla or the armpit. So you don't want to be going lower than this. If you go too low, there's a risk of injecting into the radial nerve. And if you go too far to the side, left or right, you can inject into the axillary nerve. And so injecting into a nerve can cause paralysis and or neuropathy. You should watch out for burning and shooting pain during the injection. Symptoms start immediately, and so you will know immediately if you've hit a nerve or not. A couple of tips for injecting. So you want to be holding the needle like a pen, and you want to be going quickly. You don't want to be injecting slowly. Consider vaccinating the non-dominant arm. So one of the first questions I ask is, are you right-handed or left-handed? And if they say right, I ask them, is it okay to inject your left arm? Usually there's no problems there, but basically the non-dominant arm is usually the arm where we inject. Landmark the area on the deltoid. Cleanse the skin with alcohol, and remember that you should let this dry. Quickly inject at a 90-degree angle all the way to the hub, which is the plastic bit. Depress the plunger at 0.1 mL per second. So flu vaccine, typically 0.5 cc, so that will take about 5 seconds. You quickly remove the needle at the same angle and apply some pressure with a cotton ball or gauze. This is something called dimpling. So usually this is caused by not giving the vaccine quickly enough. You want to do like sort of a dart motion when you're administering the vaccine so that it goes into the skin and it does not create a dimple like this picture on the bottom right. Immediately after, activate the needle's safety mechanism, if available, and you should dispose the vaccine in a safe container, like a Sharps container. And you're done. So put a Band-Aid on, good job. So what if you have to give more than one vaccine in a day? There's no hard and fast rule. You can give more than one vaccine in a day. Typically, you want to rotate the injection site. So if it's 2 vaccines, 1 in both arms. If it's 3 vaccines, you could do 2 in 1. You would have to space out the 2 injections by at least 1 inch or 2.5 centimeters from each other. And typically the zone, the triangle that we're trying to landmark, usually that area is large enough that we can do 2 vaccines in there. What if the patient has a tattoo on their arm, like the picture on the right here? So in this case, you want to landmark as you do normally, but the risk of tracking ink into deeper tissue, there is a theoretical risk that the ink will be tracked into the deeper tissue, but it's a theoretical risk, and so usually the benefit of vaccination outweighs this theoretical risk. If they have a scar on their arm, typically better to avoid this. Try the other arm if possible. Same with a tattoo. What if you reach the patient's bone with a needle? Not a big deal. Patients don't typically feel this. Just simply pull back the needle a little bit, and you can inject as normal. Okay, so these are the possible side effects. Common. The rare side effects are quite rare, 1 or 2 cases per 1 million flu vaccines. And monitoring, you should tell the patient to stay in the pharmacy for 15 minutes with a responsible adult, who could also notify you if something goes wrong, and consider 30 minutes wait time for patients with a previous reaction. And then afterwards, you can document all these components. So I will hand it back to Kevin to talk about anaphylaxis.
Hey, Pior, I have a quick question for you. How are we doing on time?
We are doing fine. We are doing fine. It's nearly 10 o'clock, so we have still half an hour.
Half an hour? Okay. Quickly talk about anaphylaxis. I'll try to brush through this for the sake of time. But basically, anaphylaxis is a severe, life-threatening systemic hypersensitivity reaction involving 2 or more systems or the respiratory tract. It is mediated by Ig antibodies or immunoglobulins that respond to the presence of foreign agents and can be fatal if untreated. Anaphylaxis has been proven to be causally associated with vaccines and is preventable in many cases and treatable in all. So the signs and symptoms of anaphylaxis typically develop over several minutes, and the main features are itchy urticaria rash, progressive and painless swelling around the face and mouth, and we call this angioedema, as well as a sudden drop in blood pressure. We have sneezing, coughing, wheezing, trouble breathing. This can be due to upper airway swelling, possibly causing an upper airway obstruction. And then we have crampy abdominal pain and vomiting. So these will be your typical cardinal symptoms that you'll be looking out for in an anaphylactic patient. In terms of pathophysiology, anaphylaxis is initiated by an allergen or an antigen interacting with allergen-specific immunoglobulins on mast cells, causing the release of these preformed mediators, enzymes, and cytokines. These mediators work directly on tissues to cause these allergic symptoms, or they can recruit or activate additional inflammatory cells. Certain mediators, such as nitric oxide, have this potent vasodilator activity, causing hypotension that we see in a lot of patients, as well as smooth muscle spasms that occur in these upper airways, causing bronchospasms, therefore reducing one's ability to breathe. So assessing your patient, most reactions will occur typically 30 minutes after your injection, which is why we ask our patients to wait 15 minutes. And mild symptoms such as rash, itchiness should not be ignored, as they may be quickly escalated to a systemic response. Initially, when managing anaphylaxis, you'll want to assess your patient's ABCs, so airway, breathing, and circulation, checking to see if their airway is compromised, if they're breathing, maybe taking a look at their heart rate, as well as looking at their capillary refill time. Assessing the patient for any angioedema and making sure that someone calls for help or emergency services. The patient should never be left unattended, and if the patient is not edematous, they should be placed in a recumbent or supine position, basically lying down with their lower extremities elevated to maximize perfusion to the vital organs. The treatment for anaphylaxis is epinephrine. This is the first and most important treatment and should be administered as soon as possible to prevent any life-threatening symptoms from progressing. So epinephrine is available in pre-filled syringes, as you can see here. We in Canada have EpiPens, and it's also available in ampules of 1 milligram per mil. And basically what epinephrine does is it's binding to your alpha and beta receptors, stimulating the sympathetic nervous system to relax bronchial smooth muscle, as well as increasing blood vessel constriction, fighting off that hypertension. In terms of administration of epinephrine, the recommended dose is 0.01 milligrams per kilogram with a max of 0.5 milligrams per dose. To avoid delays, because we're trying to basically treat the patient as fast as possible during these situations, we typically follow these rules. So for infants and children under 30 kilograms, we'll give them 0.15 milligrams by auto-injector or the 1 milligram per ml solution. And for patients that are over 30 kilograms, we'll give them 0.3 milligrams by the auto-injector or 0.3 mLs of the 1 mg per ml solution. And these dosages can be repeated at 5 to 15-minute intervals if necessary for a total of 3 doses. Now, even if you do administer epinephrine, you should be sure to be calling emergency services. The intramuscular injection is the preferred route in all ages, and the preferred site is the anterior lateral side of the thigh, as you can see here. If clothing cannot be removed, epinephrine can be given through clothing as well. This is more for your reference. This is basically a dosing chart for intramuscular epinephrine, and this was adapted from the Canadian Immunization Guide, so you can take a look at this in your own time. We'll go over this an EpiPen as well. I don't know if you have EpiPens in Poland. However, if you do, this is a good review. Basically, you're removing the EpiPen auto-injector from the clear carrier tube, removing the blue safety cap by pulling it straight up and swinging the orange tip against the mid-outer thigh or the anterior lateral region until it clicks, holding it firmly in place for 10 seconds, and then removing the auto-injector from the thigh, massaging the injection area for 10 seconds. And as you can see here, it's very detailed. All the instructions are on the EpiPen as well. The next thing I will talk to you quickly about are vasovagal reactions, basically syncope or fainting. The signs and symptoms of this are typically pretty rapid. It has a rapid onset. The patient goes from normal to unconscious within seconds. They go pale, and they exhibit this clonic seizure activity, so these jerking movements as well that are typically benign, and they will collapse. In terms of management, you'll want to place the patient lying down with their feet elevated. There is a risk of head injury since they are collapsing, so you'll want to be able to catch them quickly and assist them to the floor. You can apply a cold compress to the neck or face and also check their blood pressure. And once they regain consciousness, you can have the client sit for a few minutes before standing back up. Typically, clients will tell you if they have a history of fainting. with immunizations, and these patients are recommended to be immunized lying down. This chart here can basically helps differentiate between anaphylaxis and vasovagal syncope. In terms of onset, anaphylaxis occurs 5 to 30 minutes after vaccination, whereas vasovagal syncope will occur before, during, soon, or after. Typically, patients who have anaphylaxis will describe it as sort of like an impending doom feeling, and patients with the vasovagal syncope will have fearfulness, lightheadedness, numbness, and weakness. The big one to look out for is the skin. So patients who are anaphylactic will exhibit hives, the swollen eyes and face, or the angioedema, as well as a generalized rash, whereas patients with a vasovagal reaction will appear pale, sweaty, cold, and clammy. Another thing to look out for is their breathing. So anaphylactic patients will have airway constriction, so they'll have noisy breathing with wheezing or stridor, whereas other patients who faint will have normal to deep breathing. And then with neurologic, that's another big one to look out for. With the loss of consciousness with anaphylaxis, there will be little response once they're supine, whereas with a vasovagal syncope, they'll have a transient loss of consciousness and they'll have a good response once they're supine. And then you can also look out for those tonic-clonic seizure movements as well. And I'll hand over this to Alex for the last portion of this presentation.
So I'm going to talk about these. So we had a patient survey that was sent out just to the general population to get their thoughts and their opinions on vaccination in Poland, as well as pharmacies injecting. So it's just to highlight what people are currently thinking. So of course, this is not fully representative of Poland, but it has a good. We have about 1,100 participants. So one of the questions that we asked was, when was your last immunization? And the reason I bring this up is because so only about a quarter of the respondents had a vaccine in 2020. So basically, the remaining 75% of candidates are candidates for the flu vaccine, since this is an annual vaccine. So this represents a large population that we can inject. And similarly, the tetanus booster is done every 10 years. And so basically green, purple, and blues, these people have not had vaccinations in 10 years. And so they would be due for a tetanus booster. So again, this is identifying patients that can receive some shots, some vaccines. Here, I just asked the general question, have you ever had a flu shot? Most people have not. A good proportion of them have had their flu shot. But basically, this represents another population that we can target and sort of nudge them a little bit closer to getting their annual flu shot. Again, this is just a question to see the difference between the distance between a pharmacy and a doctor. So in most cases, the pharmacy is closer to the patient than the doctor's office. And so we also had a second question that asked had patients agree or not agree. The question was, pharmacies are more accessible than GP offices, and about 85% of people said strongly agree or agree. So vaccination in pharmacy is definitely a viable option. It's accessible. You just have to get that person in there. And 60% of respondents strongly agree or agree that it would be faster to get vaccinated in a pharmacy than it would be in a doctor's office. And I also asked the question, why, if you have not gotten a vaccine, why not? And so some of the most common reasons are distrust in vaccines, that pharmacists are not doctors or they're not qualified. They never got the flu before. They're afraid of vaccines and or needles. They want to build their immunity in other ways. And some people said, I'm already healthy. And so that was the reason for not getting the vaccine. So basically what I'm trying to highlight here is that there's a lot of misconceptions regarding vaccines and immunizations. And so as a pharmacist, you should be trying to correct misconceptions and give them correct information so that they're actually making informed decisions and not based on misinformation. And my last slide here, I just want to go over a few practical examples on how to identify vaccine candidates in your pharmacy. So I have here a few vaccines that are regularly given. So for example, patients with diabetes, if they're just starting on metformin or a diabetes drug, you can ask them, have you had the vaccine for pneumococcal vaccine. Similarly, if they had a chronic lung condition or if they had a cardiovascular event, again, this could be an indication to start the pneumococcal vaccine. So this is all about identifying which patients can be vaccinated. Similarly, with the herpes zoster vaccine and the meningococcal vaccine, usually indicated for immunocompromised patients. Again, influenza vaccine, pretty much recommended to all patients unless it's strictly contraindicated. So either the age or previous sensitivity to the flu vaccine. In Canada, we also do travel vaccines, and so we're also able to charge them a little bit more for the service, and so that also represents an increased revenue for the pharmacy. And HPV is also a vaccine that's recommended in our younger population in Canada to reduce STIs and the rate of cancers. So all this to say, recommendations depend on the guidelines, and these are general guidelines for Canada. Of course, you would have to look at what the recommendation is in your own jurisdiction before continuing. And that concludes this portion of the presentation. Thank you.
So thank you very much. Now we could basically ask you some questions. Hello, everybody. So we have some questions actually on the right side. Did you experience any problem with vaccination in your daily work, like being accused of causing side effects? Do you have any kind of insurance covering such situations? And this is a question from basically to everybody now. So from my Canadian team, please, what is your experience about being persecuted or accused of side effects, and what about insurance covering?
Yeah. So in Canada, pharmacists need some sort of liability insurance to practice. And so this would protect us from like legal costs if that were the case. But if a patient is going after you because of a side effect, it's not really something you can prevent, right? It's not something that it's not the pharmacist's fault. This is an expected side effect of the medication. And so first you would have to correct that misconception that, I didn't do this. This happened because of a side effect. It's not because I don't know how to do vaccines. So you want to make sure that they're aware that this is a side effect. I don't know.
So this is Anko. I'm one of the director. I'm the director of pharmacy here. So basically, in Ontario, there hasn't been any cases of pharmacists being sued for giving vaccine. We've been giving vaccine, I would think, for about 10 years now. So it hasn't been an issue. So the ideal case is usually for the pharmacist that wants to, it's there as required, but it hasn't been used for that purpose.
What about Eva and the rest of the team? Marta? Eva, unmute your microphone. Yes.
Okay, sorry. I think it's super important that a part of your consultation is actually emphasizing that there might be side effects, and it's our job to list the most common ones. So, like soreness and tenderness around the injection site and flu-like symptoms. You just talk your patient through it. You tell them what they can expect. They have to consent for that. You're not going to chase them around the pharmacy with a needle and stab them when they stop running. And yes, we do. I'd say every pharmacy and pharmacist have an insurance, not only for the flu vaccination, but we know that there's other instances where such a thing is needed.
Okay, Bolesław?
Muted.
You muted. Ah.
Is it all right now or not?
Yeah, all fine, yeah.
Okay, right. Answering the first part of the question, during the process when you vaccinate, first you need to have an honest conversation with the patient. Then if the patient has got any queries or is afraid about any side effects, you can give them examples, you can give them proper answers. And at the beginning of the vaccination, before you do anything, as mentioned, Eva, you need to have a consent of the patient, and you filling in the questionnaire about the medical history, about the previous experience with the vaccination. Talking about the insurance, every pharmacy in general needs to have insurance for any errors in UK. And as a pharmacist, you've got separate insurance. Most of the people probably got from Pharmacy Defense Association, which
it's a trade union, yeah?
Exactly, trade union, which is something similar in Poland, and which Piotr can say something more about that. And yeah, as an individual, normally you've got a normal insurance, and when you renew your insurance every year, you can add that from this year, for example, you're doing vaccination, then you're paying extra, or sometimes it's the same price, and you covered.
Okay, this is cool. Jarek, can we just also show Marta, please, for a second, that she could say us? Okay, Marta, and what about you? What about insurance and risk? And
like, I'm in Ireland, same as Eva, so it works the same way, I would say. Generally, there is no problem with it, because patients who come to the pharmacy for the jab, they have to give us the consult, like, I would say 3 times. And as the guys from Canada said, any side effects is related to the vaccine, not to us giving them the vaccination. So no problem with it.
Okay, we have another question about the space or room for vaccination. And actually, I want to ask our Canadian friends, because I've heard that they are doing the sort of Mac Drive vaccination center, that people just come on the cars and they're just showing the the hand, and basically somebody's doing vaccinations.
You're talking about our drive-through vaccination that we had a couple of months ago? Yeah, so Regis had organized this vaccination clinic basically in one of the parking lots of the hospital that we worked in. And it was a drive-through clinic, and it was really efficient, actually. So people were just getting out of the cars, or they were staying in the cars, and we would inject everybody in the car, and then they would be on their way. They'd have their consent forms already filled out. And I think we did like 1,200 patients within 8 hours or something like that. It was ridiculous.
So what was your daily vaccination rate? Can you just repeat? Because I think I've overheard something. Is it really?
So for that drive, we did 1,200 patients in 8 hours.
Oh my God. Oh my God. I think we should learn. So we should share this movie with the stakeholders from today. That's unbelievable. And do you have anything like that in the UK or Ireland?
But we can do the vaccination outside the pharmacy. So I've vaccinated people beside like a kitchen table, for example. Yeah, it's fine.
So it's not really like a room-dependent project.
No.
I would say that you need a special. Yeah. And actually, Marta had a very good idea, because we have these clean rooms in Polish pharmacies, and I think her idea is very good. Where you do the antiseptic and compounding, it's always very clean, and it's much better than the director's office, definitely. Yeah. And I think she thought a very good idea. I mean, nobody thought about it yet, so I think today we have a newsbreaker, definitely, for the evening. Excellent. We have one more question. Except those that they love our speakers today, and there's one more. Give me just a second. Just a second. Okay. We noticed that people in Poland, they are not so keen to get the flu jab. What about UK and Canada?
I mean, in Canada, people are pretty keen on getting their flu shots. We noticed a pretty steep increase of patients during that time. It's.
Let me add to this. So I was responsible for the hospital vaccination program this year, and usually we get 62% of the staff vaccinated. This year, we get 72% of the staff vaccinated within the hospital. People working here, 72% get vaccinated, so it's pretty good. And usually in the population, I think it's about 50 to 60% on average, especially this year, because they were afraid to get COVID with the flu vaccine, with the flu at the same time.
And obviously, the role of pharmacists educating is extremely high, especially when you just mentioned the risk groups, like diabetic and people taking immunosuppressants. So there's a large group of patients who should have it. We have another question. What was the most challenging for you all once you started to do vaccines? What was the challenge? So our Canadian friends first, please.
I would say it's the first patient that you do. I think your person in the UK earlier said it, is to get into the humps of giving an injection. After you're giving 2 or 3, it's just very routine. It's very simple. It's easy to do. And actually in Ontario, I was involved in, we're going to get the pharmacy technician to give the COVID vaccine. So that as of now, they have to get some training. It's really to get over it. And when you're perceived as a healthcare provider when you start giving vaccine. Sometimes when you don't do this, they perceive you as a merchant. But when you start giving the vaccine, they really start to perceive you as a healthcare provider. The big chain of pharmacy also got really excited about the vaccine because don't forget, the patient has to spend 15 minutes in their shop waiting for the adverse reaction. So what do you do in a pharmacy for 15 minutes? You shop and you buy stuff. So the big chain of pharmacy called Shoppers Drug Mart is always the first one to get the vaccine out. We're all upset about this one because it brings people in and they have to do a lot of shopping. So professionally, you have a good relationship with the patients. From a money point of view, it brings business into your stores and they buy stuff. Because what do you do for 15 minutes? You just get bored and you buy stuff. So it's been very well received by the professions. That's about in Ontario, there's about 4,000 pharmacies, about 3,500 are giving the flu vaccine every year.
Mm-hmm. And what about like if somebody's allergic to mites or dust? What about the vaccine? Is it still recommended to provide? I think it's not really relevant, isn't it?
No,
Yeah.
it's not.
Okay. And what about pollen allergy? Not really.
As I know.
Mm-hmm. Another question, is there like, how much time do you spend basically average to examine the patient? I mean, mainly it's filling the form really, isn't it?
And I'd say most of us, although the patient had filled the questionnaire themselves, you still go through the questionnaire with the patient to make sure that they understand what was what they were feeling. Like, for example, the part of an Irish questionnaire is like you have to list all your medication, medical conditions. For whatever reason, majority of my patients just don't even see that, don't even bother filling that bit, which can be sometimes a significant, well, it is obviously a significant information whether or not we can proceed with the vaccination.
And what's the average time, do you think, for the whole process?
Well, excluding the
including the interview vaccine.
I'd say if you're good organizer, less than 10 minutes.
So
the more you do it, you have your routine, and you've got this thing. You say da 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 da. You say this is what's going to happen. This is what I'm going to do. And you sort of said, do you have any questions? 9 out of 10 times they'll come back because it's another year, and again, they had the flu vaccination before, so they know what to expect. So that drastically shortens the time of the consultation with the patient.
Mm-hmm.
So it's estimated that for the COVID vaccine that for the first vaccine, if someone prepares the dose for you, you can do 14 patients per hour. If you have to prepare your own dose, like do it yourself, it could be about 10 to 11 per hour. If you only do this, so it doesn't take that much time. So it's possible to do.
Mm-hmm. And is there any advice you could provide to the Polish pharmacists who are shortly hoping to get this process in place? Because that's what the government decided. And what's the most important advice for them? I mean, some of them, as we know, they're not really convinced about the process. But as you say, I mean, it's easy and it's not a big problem. So what would be your like 3 key advices for our Polish friends? It's a difficult one.
I'd probably say don't be scared, because I know it sounds petrifying, especially knowing what kind of training we got in the university. That might be a bit scary, but you have to remember, you guys are healthcare professionals. You're not just qualified drug dealers. There's so much more that a pharmacist can do other than dispensing and checking.
Absolutely. And there's one more question. Like, okay, before I'll just ask my Canadian friends and Bolesław from UK. Kevin, Alexander.
From my perspective,
What is your
definitely from my perspective, because through my life I was quite never keen on needles. I hate needles. Then I overcome this problem, and I think as a pharmacist, if you go on the course, you will see how it goes on the course as an individual. They teach you exactly what you need to do from the practical point of view. You would have face-to-face conversation. You go step by step how to do it. You would have standard operating procedures, as Eva was explaining, like in the sense how to do the whole process to be safe. And you would have as well like a theoretical knowledge. And as the Canadian guys mentioned, is changing from the perspective of the organization, it's changing the perception of the pharmacy. Because, for example, in UK, the whole process of flu vaccination, it started 2013-14. That was the trial. In 2015, they vaccinated 500,000 people in the pharmacy. 3 or 4 years later, they vaccinated nearly 2 million in the pharmacies. At the beginning, the people were saying, you know, do you want to be vaccinated in the pharmacy? They were saying, no, I'm already booked with the GP as a doctor. But afterwards, when they see the convenience, the people really appreciate that they can come to the pharmacy, walk in, they can book appointment, it's not a hassle, and you are as professional as done this in the pharmacy by the nurse or by the GP, and the whole process is done, and it's definitely quicker, and for the system, as a healthcare system, it's cheaper as well. Then it's a win-win situation in general.
Mm-hmm. And Canadian friends? Free point.
I mean, I might be reading, but like again, it's just to be confident. Like as a student, when I first had to learn about this, it was a very daunting experience, as I guess I would say. But as you do your first patient, and as you do more patients, you build like confidence, and it becomes more of a routine. And I find, you know, giving flu shots is a great way to build patient relationships as well. Building that trust with your patients and having them come back again the next year for their flu vaccine once again. So, you know, again, just be confident.
So I would add to this, it also becomes a competitive advantage over the farms that do not do it. So if you're a pharmacy and it was very well spoken before, like patients seem to enjoy it after a while. So if you provide the service, you provide a better service than the farms who doesn't do it. So to me, that's the other advantage. And I agree with when the co-presenter, just do it. Just do it. Go over your head. You're scared. It's no big deal.
Mm-hmm. Marta? Free advice for your friends from Poland.
I would say, like, just don't be afraid. That's easy peasy lemon squeezy, you know. And I would say that can just improve the perception of pharmacists in Polish community, because I believe that people think pharmacists are just drug dealers and supplement dealers, not fully qualified and not professional. So and just use the opportunity to build relationship with the patient, because like big chains, pharmacy chains, are gonna take your place in that case. They won't wait.
Great. And we have last question. Do you have to clean basically the place before and after? Or because I think there are two different schools, that some of them, if the patient is socially clean and he's not dirty, you can do it anyway. And some people, they advise to clean before and after. So what is your opinion on that?
I think in today's world with COVID, I would clean before and after every patient in this case.
You don't see the room between
the environment you work in,
Yeah, but like in Ireland, you don't have to clean the skin before you do the job.
Right. Yeah.
Actually, WHO came up with a statement that alcohol swab is not required for the skin.
Exactly.
So requirement. In Canada, we're still doing this, and we're going to be doing it for COVID-19. I think there's still some requirement for multi-dose vials to swab the vial before you use it.
Yeah,
so there's no requirement for doing the shoulder.
Mm-hmm. Yeah.
Myself, I don't like doing the gloves. I hate latex gloves. I mean, the glove juice when you're sweating, this is terrible, and I have problems to basically hold the needle, and I prefer to do it without it. So for me, it's just I mean, this is what I really like. And myself, what I didn't like really, it's a BLS, basic life support. I hate it. I mean, especially that you have to repeat it every year. I don't have any kind of how to say, good positive emotions about it. I don't like it in general, and the rest is fine, absolutely. I mean, my first obviously opinion about blood and stuff and doing injections, it was like very difficult, but then actually I realized it was one of the best courses in my life because it was extremely practical and it's easy in general. So I could learn so much in like 12 hours of the training online plus the theoretical. So I've done it twice because it's renewable. So every 3 years you have to renew the training, and I like it a lot. We have a last question here from Alicia. Personally, she's very scared about the responsibility for adverse reactions, and facing the patient, they don't understand what would happen if, for instance, the process is okay with the injection, but then basically the side effects are a problem. So even if that's unlikely, this is also very scary for her. Hope I have more courage eventually to do them. So I think it's only the practice, isn't it?
Yeah.
Yeah, but also, if you want to just change a bit the profile of the profession from just selling medicines to somebody who's more medical, you have to take responsibility. But this is something encouraging and rewarding job, especially when the patients are happy. And this is something I'm missing in Poland a lot, basically. The medical role mainly.
Exactly.
So cool. Are there any questions? I think we are just done on time today. Excellent. And just taking the opportunity, I would like to thank you, Dr. Regis Vaillancourt, for helping me to organize this course. It was great. And I also want to mention Pharmacists Without Borders. This is one of the best education projects on the planet. And we are proud to run this project here in Poland. Now we are waiting for the 5th edition. Unfortunately, due to COVID, it was stopped and we cannot sort of process it, but hopefully we'll come back with it. I want to tell you also that we prepared a very good project with vaccinations. It was the first in Poland pilot that was run in 2019. We had 2 sessions and there was around 700 pharmacists trained in the training. And we also perform a research based on that. So we have a research before the pandemic and after the course and the opinion about doing the flu vaccinations. And now we are just finishing off the final research during the COVID pandemic to see whether the responses has changed. So let's wait for the results, and obviously we'll just publish and share it with you on the webinars. So thank you very much. I hope that you found it very interesting, and the most important thing about these webinars is to bring you the specialists and the experts with a very large clinical education and expertise, and something that doesn't exist in Poland yet. We are trying to build it with help of our friends from Canada and also Ireland and UK. And so all the best for you. Thank you very much once more also to Pharmacists Without Borders for organizing this course with us. So thank you very much for today. I hope you like it, and we invite you for the next one next week, basically. Thank you so much. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you.